Hi, I'm Susan Birch and welcome to another A Health Detective question and answer session. And today we've got Doctors Leon and Tamora Bynoe with us, and they're going to answer questions about cardiovascular health, but health in general. I just want to point out that they can't give you specific medical advice because they're not your actual physician. But what they can do is give you food for thought, give you some better understanding perhaps of any problems and conditions you have, and enable you to go back to your own medical specialists and ask better questions and have a better understanding. So we love questions, so please make sure you send them in. So welcome, guys. Thanks for being here.
Thanks for having us.
Thank you.
It's always such a pleasure. So the first question I've got for you is about the difference between good health and managed morbidity. So would you like to talk about that? That seems a great place to start, really.
Okay. Yeah. Well, yeah, this is something that I guess was sort of an epiphany for both of us because, you know, I would say that I never knew what good health was until I was probably about 55 years old. I think a lot of us go through life with things that are happening to our bodies and we just think that it's normal, or we just think that we're getting older, so it's normal. And it's only when you don't have those things anymore that you realize all that time that no, you just weren't healthy. You know, those aching knees that I had for seemed like decades. It wasn't just I'm getting older and running. Because I run, my knees are going to clot because now they never hurt, you know. But I think that's true for a lot of other things, like the high blood pressure I used to have. I mean, I thought I was healthy, but my blood pressure is going up, but now it's not.
And you also think, oh, because I'm put on medication to manage it, I'm healthy. But no, all you're doing is treating a problem without treating the root cause. So you're just managing your disease, but you're not treating the root cause of your disease. And so many people in the Western world with our Western diets have managed morbidity.
And it goes even further because it's not only managed morbidity, but we actually were causing our morbidity. That's the revelation that we came to. I was only hypertensive. Tamora was only becoming diabetic. And people have only the reason they have all these kind of things is because of the diet environment that we find ourselves in. And again, I only know that now because all of those things have vanished now that I'm eating differently. So what that informs us is that, you know, that it's not only that it's not normal to get these things. I've come to the conclusion that we're causing these things. And there is also a lot of evidence to support that. The fact that all of these things are leading causes of morbidity and death now were not very common only a couple of hundred years ago. And there are places on this planet right now where people just don't become obese as they get older. They don't get hypertensive. They don't become diabetic. They don't get colon cancer. They don't get all kinds of things that we think are just, oh, well, you're getting older, this happens. No, they don't get them, but they're just humans like you and I, and it turns out that it's not because they're genetic supermen, but if they come and do the same kind of things we do, and they're in the same food environment they were in, within one generation, they're just like us. So that's what I mean. I think, you know, discovering what good health is. Good health is basically being healthy and not needing to take anything to stay that way, other than food.
So I have a question here about cholesterol. And so the question is, does that mean that I'm causing my high cholesterol by my lifestyle? And do I need to be on a statin, or can I lower my cholesterol naturally?
Okay, so I'm presuming this person's talking about LDL cholesterol?
I would presume so.
Yeah, or it probably LDL cholesterol and total cholesterol.
Or total cholesterol.
Or total, or probably both. Yeah, funny story. Well, you know, I think we need to kind of prioritize what we're saying are the healthy markers or the markers of health. So people might be familiar with the term metabolic syndrome. So metabolic syndrome consists of 5 characteristics: blood sugar, blood pressure, serum triglycerides, serum HDL or high density lipoprotein, and belly fat. Those 5 things are define metabolic syndrome. And all of those things are very important markers of health, because when you look at the studies and how much they're associated with bad outcomes and cardiovascular disease specifically, all of those have very high hazard ratios. I think all in excess of 300 or 400%, going all the way up to 1100% for diabetes. And I'll just briefly describe what I mean by hazard ratio. So when you do these studies and you're looking at factors, the hazard ratio is an expression of basically the statement, how many times more am I likely to get this if I have that? Okay, so and it's math and epidemiology, but it can be useful. So for example, with cardiovascular disease, just having a belly raises your risk of cardiovascular disease 400 to 500%, meaning that you're 4 to 5 times more likely to develop cardiovascular disease or have a cardiovascular event just by having a belly. And same is true with hypertension. And with diabetes is as much as almost 1100% or 11 times more likely. And so I think metabolic syndrome was defined by those 5 factors. It's because they seem to be very relevant and very important. But the same cannot be said for LDL cholesterol and total cholesterol. Their hazard ratios always tend to be under 200%, meaning that it doesn't even double your risk of getting these things. Whereas just having a belly almost quadruples or quintuples it. Okay, so that has to right there has to make you wonder, well, how important are these risk factors? How important are this cholesterol, LDL cholesterol, and total cholesterol? And then there's a lot of other data that strongly suggests that LDL cholesterol and total cholesterol are not causing significant disease in humans. David Diamond has done some brilliant research looking at people who have the highest cholesterols imaginable, people with familial hypercholesterolemia. And he found, of course, if LDL cholesterol and total cholesterol were causing cardiovascular disease and heart attacks and strokes, you would expect that these people with the highest cholesterol would be getting this a lot more and dying at a very young age. Well, when he looked at the people who have this disease, found that actually they don't die young. They live normal lifespans. And after the age of 60, their mortality is actually decreased, meaning that they actually appear to be healthier after the age of 60 compared to everyone else. Now, he did find a subgroup of people with familial hypercholesterolemia who have cardiovascular events in their 30s. But as it turns out, this subgroup are people who were either smokers, or if they had some form of metabolic disease, if they were hypertensive or they had high blood sugar. So basically the same things that are the important risk factors for everyone else. So if you have a super high cholesterol and you're diabetic, yeah, then you're probably get a cardiovascular event in your 30s. But if you're metabolically fit, so if you have those 5 factors of metabolic health, normal blood pressure, normal blood sugar, normal triglycerides, high HDL, and no belly fat, the data strongly shows that you live longer despite having a high LDL cholesterol and having a high total cholesterol. So that right there makes you have to question, well, how important are these factors? And then there's one other thing, which is actually the way we all met. This is how we met Sue Birch and Tamora and all, is that there appear to be a bunch of people who they're not healthy. They make themselves healthy with things like intermittent fasting, ketogenic diet, carnivore diet. So they basically transform their health, just like Tamora and I did, where we're very unhealthy, and they get themselves very healthy, super fit. And a lot of times they're not just fit, you know, they don't get colds or flu. They don't have any joint pain. They're perfectly healthy. And all their metabolic syndrome factors go in the right direction. Their HDL is high. Their triglycerides are low. They have no belly fat. Their blood pressure is perfect. And their blood sugar is perfect. They do that, except their LDL and their total cholesterol shoots up. And so that, exactly, this is how we all came to be, to know each other, is because we did, but look at what we did. We lowered all the hazard ratios that are really high. For example, Tamora was becoming diabetic. That raised her risk of cardiovascular disease 1,100%. So by not being diabetic, she's decreased her risk 11-fold. Now, back when she was pre-diabetic, and also back when I was hypertensive and obese, my LDL cholesterol was like 130s, they're 139. And hers was, you know, they're basically normal. But that hazard ratio is only decreases our risk 38%. Okay. So by the numbers, it basically, it seems if you want to give yourself your best chance of good health, you need to be metabolically fit. And furthermore, it seems like if the cost of getting yourself metabolically fit is to raise your LDL cholesterol or in your total cholesterol, two factors which have among the lowest hazard ratios of the risk factors that have been established, it still seems like you're way ahead of the game. But then there's one other thing too. There is some data that suggests LDL actually may be good for you. Understand, LDL is a molecule that's largely made by your own liver. And it doesn't make a whole lot of sense that your liver is just making something that's going to kill you and give you a heart attack. More likely it's making it for a reason. And one of the reasons may be that the LDL cholesterol molecule, I mean, that's one of the backbones, or the cholesterol anyway, it's one of the backbones of a lot of our immune mediators. And so, and of course, a healthy immune system is something that'll increase your longevity as well. As a matter of fact, that might be why people with familial hypercholesterolemia, why their mortality is lower after age 60. Maybe they're not getting sick as much as everyone else, which also is something that we have found. Since when my LDL was 139 and I was obese and hypertensive, I was also getting colds about 2 to 4 times a year. I would get a sore throat or sinusitis. I mean, it was my whole life. And then when I got fit and my LDL shot up, I haven't had a cold since. I never get sick. I never get anything. So, yeah.
I can speak to that because I've had high cholesterol my whole life. So, it's familial hypercholesterolemia, but I've only had the flu twice in my life. I survived meningococcal meningitis. And I'm really healthy. But I just have this, like nearly 700 in US markers, 17 in New Zealand markers, which is astronomical. And it gives the cardiologists gives them a heart attack.
Yes, yeah, exactly.
I've got a great question that's just come in, which kind of continues on what you were just talking about. So, hi, I'm currently a third year medical school. And one of the main things they hammer into us is that LDL cholesterol plays a major role in the development of atherosclerotic plaques. Do you know what the mechanism is if high LDL doesn't necessarily contribute to it? And I'm just going to say for this person, go and check out Malcolm Kendrick's latest.
That's what I was just going to say. I was just going to say that.
He answers that question very clearly for you.
Yeah. I was just going to say that because here's the thing, the people who propose this hypothesis, they don't have a good mechanism for how it's actually doing that. That's what I think is funny, because they don't have a plausible mechanism for how LDL is causing disease in humans. Basically, they have one piece of data where they find, sometimes you find cholesterol inside of plaques, okay? And that's it. They don't know how it got there. They don't give a mechanism. They don't give a proposed mechanism for how it gets there.
Well, they give a proposed mechanism, but this doesn't.
Well, I'm sorry. Yeah, the mechanism they propose makes zero sense. Yes.
High volume of LDL cholesterol in your blood somehow bombards and makes its way through your endothelial lining,
past receptors,
past everything that your body has designed to prevent this, passive of things from inside your vessels into the wall. And, and for them, just the presence of high LDL is enough to cause this transition from LDL cholesterol in the blood vessels into the walls of your coronary arteries. Doesn't make much sense. Which is why, going back to Dr. Kendrick and his proposed mechanism, which makes a lot of sense, is that there is a damage done to the endothelial lining and the inside of the coronary arteries that now allow passage of intravascular mediators through the endothelial lining into the muscle. And there's, so there seems to be damage to the endothelial wall, inflammation to the endothelial wall that allows passage of substances into the artery muscle to build up the atherosclerotic plaque. So that's what we say. If you have an intact endothelial lining because you're healthy, metabolically fit, you're not hypertensive, you're not diabetic or hyperglycemic, then you should have no concern of damage leading to atherosclerosis in your coronary arteries.
Basically what we're saying is that LDL is not going to get in unless it has an opening. Right. It's just like and the thing is, it's a very simple way to think about it. It's just like if you cut yourself on your skin. If you cut your hand, eventually you form a clot, and first it'll bleed, then you form a clot, and then over time that clot hardens and eventually it becomes a plaque, and then other cells come in and remodel the area, and ultimately it'll heal, okay? It's the same thing on the inside of your blood vessels too. But basically, it's not like all of a sudden you just form plaques under your skin for no reason. No, you have something that injures it that causes this cascade of events. So and it's not the fact that you're on the inside of your blood vessels because LDL cholesterol is floating around in there. It's just there's no mechanism they've shown where it actually itself causes damage to the cell. They've never shown that. Okay, whereas we do know a lot of things that damage the inside of your blood vessels. We know high blood pressure does it. We know high glucose does it. Okay, we know sickle cells do it. And Kendrick gave a brilliant explanation of this. Is that if you look at the things that have the highest hazard ratios for causing cardiovascular disease, he said, if you look at them, you really would have a hard time making any connection between these factors. But if you look at what they can do, then it all makes sense. So the thing that sickle cell anemia has in common with diabetes and hypertension is that both can directly damage the endothelial cells. Sickle cells, by a more mechanical, physical thing, basically spiky blood vessels that are physically injuring the inside of your blood vessels. And diabetes and more from a chemical thing, because glucose in high quantities is toxic to endothelial cells. Hypertension probably just from a pressure effect, but basically they can all do this. And the thing about all of these that LDL is missing is that LDL, there is no mechanism that it is directly causing damage to the blood vessels. So basically, at this point, I think the cholesterol hypothesis is just wrong. I know a lot of people that may be controversial to say that, but the hazard ratios are way too low for it to make any sense. There's no mechanism, and now also when you look at it from an evolutionary standpoint, a molecule that your liver is making. Why would it make it? What's the evolutionary advantage of it to make a compound that's going to give you a heart attack? It doesn't make a whole lot of sense. And again, when you add that to the hypercholesterolemia, familial hypercholesterolemia, people who are healthier than normal, the lean mass hyperresponders who are way more fit than most people are. Both Tamora and I are way more fit in every way, not just physically, but as I said, immunologically, we're much more fit. The absence of arthritis I used to have, the reflux she used to have. All this stuff that we just used to have with this respectable LDL and total cholesterols, and now we're like double, and we're very fit. So all of this taken together would have to force you to reconsider the hypothesis in total. And I mean, my conclusion is that the hypothesis is just wrong.
And we see we've got the same LDL floating around in our veins we have in our arteries, you know, and it's not jumping into our veins and causing damage.
Exactly.
You know?
Exactly.
So
the hypothesis makes no sense.
Yeah. Right. So another question. Oh, sorry. Did you have something you wanted to say?
I was just going to say, because, you know, again, how we all met is through the Lean Mass Hyperresponder Facebook, but we all joined it because when we first got our cholesterol numbers back, you know, after changing our diet, we were like, oh my God, I was like, what can I do? I'm going to die, you know, and then as we learned, we had all that anxiety. And as I learned more and more, I'm at this point where cholesterol, my high cholesterol does not bother me whatsoever. Not whatsoever. I want to see, you know, what I like to see is I will look at my triglycerides and make sure they're nice and low. My HDL is nice and high. I also look at my, you know, my inflammatory markers like the CRP.
The reactive protein.
Yeah, and if that's low, I'm doing
well.
And
insulin, you know, I think insulin is such an important
and insulin as well. Like,
you know, you just know very few doctors in New Zealand will even check insulin, and they just tell.
Same here.
Same
here.
It's a complete waste of time. They tell everyone, don't bother checking your insulin. It's like one of our most important markers.
Right.
Crazy. I remember Dr. Diamond saying his doctor had talked to him about his cholesterol, and he said, I'm worried about your cholesterol. And Dr. Diamond said, so am I. It's just not high enough yet.
Yep. That's funny.
Yeah, he's quite a funny guy. My doctor wants me to go on statins, slightly high LDL, but I'm not convinced. My LDL has always been slightly high. Should I start statins and stop when I'm physically fitter and improve my lifestyle?
See, we cannot give you any direct information whether or not you can stop or should stop or start your statins, because we're not your physicians.
We can tell you what we do, though.
We can tell you what we do. I have this, I mean, if again, my blood pressure is low normal, my glucose and my hemoglobin A1C is normal, my waist to height ratio is less than 0.5. I've got low triglycerides, high HDL. So I am part of the 20%, or was it even 12% of people in the United States who are metabolically fit. The only marker that I have that would be considered abnormal is my high LDL, high cholesterol.
And total cholesterol,
high LDL and total cholesterol. And if I was told that I needed to be in a statin, I'd say, no, thank you. Because at that point, you were just treating a number. That is it.
Not only are you treating a number, but again, you're treating the lowest hazard ratios there. But let me explain more of the absurdity of putting someone who's metabolically fit on a statin, just how absurd it gets. Okay, because, and understand, remember I said metabolic fitness, we're talking hazard ratios 400 to 1100. All right. And with cholesterol, LDL cholesterol, we're talking hazard ratio of like 138. So basically it raises your risk 38% as opposed to quadrupling your risk or quintupling your risk, or I'll just say 10-folding your risk as it would be diabetes. So the absurdity of putting someone who's metabolically fit, and first thing I would say to the person is try to do everything you can to be metabolically fit. That is the goal that I want all my patients to achieve. I want them to do their best to become metabolically fit, lose the belly, get their blood pressure normal, blood sugar normal, low triglycerides, high HDL. Those are the 5 things I want to. If they do those 5 things, I think they're golden. And I don't think they need to worry about much else. Okay, but let's say you take someone who's done all those 5 things, which is basically everyone in the lean mass hyperresponders group. They've done those things. And you put them on a statin to lower their high LDL. Okay. All right. So not even talking about the side effects they're going to get, you know, the muscle cramps, the memory loss, the potential for an Alzheimer's-like dementia in people who take it long enough. But not only that, you raise their risk of becoming diabetic by 71%. Paul Mason pointed this out. So you've now raised their risk of becoming diabetic 71%. To treat a factor to reduce their risk for cardiovascular disease 38%. So you have now doubled the risk of making this metabolically fit person diabetic. And if they become diabetic, Now their risk of cardiovascular disease is 1,100%. Okay, all to chase a factor that's 38% of risk reduction. And that makes absolutely zero sense. And when I presented that to other doctors, it's just crickets. They have no answer for that. And because they've never thought about it. And to be fair, 5 years ago, I never thought about it. 5 years ago, Tamora and I, we were like everyone else. Oh, cholesterol's causing heart disease and all this stuff. And eat, you have to eat the healthy vegetable oils to keep your cholesterol low. Don't eat saturated fat because that'll raise your cholesterol. Don't eat egg yolks. I mean, we were the same thing as every other doctor. What brought us to this is the fact that, I just turned 57 and Tamora is a little bit younger. And at this age, we are more fit than we've been in decades. And I mean, we have the pictures to prove it, decades. And not just from the physical fitness, that we're lean and muscular, but the no joint aches, no pain, don't get sick, no more reflux, no infections, no UTIs, all this stuff that we just had are all gone. Okay. So when you have something like that, and the one thing that changed, I guess that someone would be concerned about is our LDL went up. Mine actually, the last I checked was 371. I had it checked again today because I'm checking some other things, but yeah, 371, but it was 139. I was a wreck. Okay. Plus when my LDL was 139, I was metabolically unfit. I was obese and I was hypertensive. So those are two risk factors that are about 400 to 500%. But I had a pretty good cholesterol, right? So no, the statin, my personal feeling is that the statins, I don't see any use for the statins personally. I don't see it. I definitely don't see it for primary prevention. And I don't even think it's useful for a secondary prevention. I think what's useful for both primary and secondary prevention is achieving metabolic fitness. I think that is the most important thing. You get those 5 risk factors in order, you lose the belly, you get your blood pressure normal, blood sugar normal, low triglycerides, high HDL. You do those 5 things, and I think your job is done, in my opinion.
And because there's different proposed mechanisms for how statins help, isn't it? Like, are they anti-inflammatory? Are they reducing inflammation? Right. I mean, is that part of the mechanism rather than actually the lowering of cholesterol?
Exactly.
But you know what else reduces inflammation? Being metabolically fit.
Yeah.
And it does a better job.
And it does a much better job of that.
Yeah. And something I'm curious to know is how much will statins actually lower cholesterol? Because my understanding is, if someone like me, so 17 in New Zealand numbers, 700 in US numbers, it's not going to lower it significantly enough for the doctors to actually think that it's making any difference to the damage it's causing.
Right, exactly. No, I think
the thing is, because I'm an anesthesiologist, so I interact with a lot of patients. I see a lot of patients, their medical history, the medications are on. And I know I mentioned last time we spoke of how I'm seeing more and more people who are actually metabolically fit. They have none of the risk factors, but they're on the only drug they're on is a statin. And I'm like, why, and then, why are you on this drug? I asked them. Oh, because my cholesterol is high. No other medical reasoning for it, just because the number is high. And so for someone like you, who, if they just put you on a statin and you wouldn't get the numbers, so they're really trying to get your LDL below 100. Yeah. That is their goal. And I think that's absolutely ridiculous. There's a goal. So, but for statins, there's something, you can't get that low. So, but they do have a new drug.
Yeah, of course they do, They
have a new drug. And that's what I, don't want to sound like we're conspiracy theorists, but to me, pharmaceutical corporations.
I'm not going to take that one either. I'm over 60.
Their goal, they don't want metabolically fit people. They want newer and newer drugs that they can try to push. And the thing is, statin drugs are the most profitable pharmaceutical there is in the history of pharmaceuticals. So, they're going to try to find, the next step. And the next step are the things like, I guess they're the PCSK9 inhibitors.
PCSK9 inhibitors.
Yeah. So I'm seeing people on that.
Another question here about statins. So you already touched on this briefly, but this person is saying that I've been on a statin for about 18 months and they mentioned I feel like my brain is foggy. I'm starting to get arthritis, and I just don't feel quite myself. But my doctor told me he changed the statin. He changed the statin, but he's told me I have to stay on it for the rest of my life.
That I find, it infuriates me, especially I've seen people who are in their late 20s, early 30s, who've already been started on a statin with the goal of them being on this medication for the rest of their lives. And the only reason they're on it, if they're otherwise healthy, is because of a number. And that is it. And the thing is, statins have side effects. And the thing is, if you're going to be on something for the rest of your life where you have the risk of, muscle damage, and your heart is a muscle as well, memory loss of dementia, because the brain thrives on cholesterol. The brain, it's so important to the brain. The brain makes its own cholesterol. So if you have a statin that's able to cross the blood-brain barrier and cause damage to your own brain trying to make cholesterol, that's a problem. And then, of course, the increased risk of diabetes, especially in postmenopausal women on statins, their risk of diabetes goes up. And you're going to be on something like this for the rest of your life. That's a problem. So to this person, again, I cannot give you personal medical advice, but what I would say is you've got to weigh the risks and benefits. Can you improve your metabolic health by changing your lifestyle? Making sure that your blood pressures, all the things we mentioned, blood sugar is normal, blood pressure is normal. You are not obese. You have good low triglycerides, high HDL. Your best bet would be to get off your statin, because if it's affecting your brain and your memory, who knows if that can be something that's permanent? Is it something that can, once you get off, will your brain recover? Will your muscles recover? Will your joint pain go away? I don't know, but.
And this goes back to the first point that we were talking about good health versus managed morbidity. And in my opinion, if you're on a medication, you're not healthy, okay? If you're
in your medication that's actually causing you problems,
well, then you're definitely not healthy. But I mean, my feeling is that you're not healthy if you're on a medication, especially if you're on a medication for something that you absolutely would not have to be on if you did some different things in your lifestyle. Now, as far as metabolic fitness goes, I'm pretty convinced that, the whole low carb, high fat, intermittent fasting, I am convinced that that will work for most people to achieve metabolic fitness. It's 2 for 2 in this household. So I mean, Tamora was, she's not diabetic. I'm not hypertensive. I'm not, we're both very fit. And we did the same thing. And then, lots of people are doing this. Lots of people are finding the Virta study from the late Sarah Hallberg. I mean, over 100 patients, bad diabetes, lots of medications. 2/3 after the ketogenic diet, 2/3 were able to get off all of their medications, and the other third was able to greatly reduce them. And this is like, I mean, for me, why this isn't like front page news on the New York Times every single day is beyond me, because you never see data like that. What do we get from the headlines? Garbage like the Jupiter study with where I think David Diamond showed this brilliantly, where they showed that taking a statin decreased mortality by, I think, 44% or something. And it was, but then when he showed the actual data, when he showed basically, instead of the relative risk, he showed where those curves were if you didn't scale it down, and basically showed that 44% reduction was like both lines were right on top of each other. If you looked at the groups, how many people died or had an event, how many people didn't die or have an event versus who were taking the statin versus who wasn't. And I think out of 100, like one was 98%, one was 96%. I mean, it was ridiculous.
Yeah, it was.
Whereas you have a Virta health study,
1.3 difference.
Yeah, it was. I mean, it's laughable, and so but that makes the headlines. Whereas the Verta Health study, where people are basically getting off all their meds just by changing their lifestyle, they literally cured their diabetes by changing their diet. And you know, crickets, you don't really see that. Again, why? Because eating steak is not going to make a drug company billions of dollars.
Yeah.
Okay, so that's what it comes down to.
So often I have clients who we have reversed their type 2 diabetes. They've lost a terrific amount of weight. They're really happy. They go to the GP for an annual blood test. Their cholesterol's gone up and their doctor goes, oh, you're doing that keto low carb thing. Well, you need to stop that right now. And they don't even want to hear about, like, then there's no curiosity. That's the bit that frustrates me. It's like there's no curiosity.
There are some though. Remember David Unwin? There are some.
Yeah. Oh, and there's a growing number, and you know,
it's slowly.
Yeah.
It's going to come from the ground up. It's not. I really don't believe it's not going to come from the physicians, because it's not what we're being taught in medical school. It's going to come from the patients doing it, going back to their doctors, and their doctors seeing the great results. It's not going to be all, as you say, there are a lot of doctors who are going to say, oh, stop doing that keto stuff. But then there are going to be a few doctors who are going to be like, oh, what are you doing? Tell me about it. I want to learn more.
Or it's going to become from doctors like us, who were like all the other doctors, and then who transformed their own health doing this. We just last weekend, we were at Tamora's 30th, oops, I guess I gave away your age, her 30th medical school reunion, and it was my 31st. And we were back, so we went back and we saw a lot of people we hadn't seen in 30 years. And so this is one way it's going to spread. Because when we walk in, everyone is saying the same thing. They can't believe what we look like. They're like, you guys look the same as you did 30 years ago. That's what they're saying to us. And of course, anytime you say something like that to me, that gives me an opening to start talking about keto and insulin, intermittent fasting and all. But the thing is when I explained to them, I said, well, actually 5 years ago, you wouldn't have been saying that. You know, I said, yeah, we do now, because and then we talk about, you know, what's evolutionarily appropriate, the fact that I think we're causing premature aging with our lifestyles, and by a lot of different mechanisms. But anyway, so many of the doctors that we talked to were genuinely intrigued by this.
Because they know the science. They understand.
Well, when they hear it explained, it makes sense. Right.
Yeah.
It makes sense to them when you say something to a doctor, even though we weren't taught this in medical school, when you explain to them, you know, like if I say, well, if cholesterol is causing a problem, how is it doing it? And they're like, yeah, that doesn't make sense. Why is its hazard ratio so low? Well, you know, why is it a fraction of the hazard ratio of all these other things?
You talk about insulin.
And then you talk, exactly.
And they and yes, it's not coming from their patient. It was coming from one of their peers.
I honestly, I truly believe that it's people like you, it's their peers that are going to make the difference. Because, you know, I've been working in this low carb, you know, diabetes, insulin space since 1998, okay? That's when I kind of had my epiphany. And, you know, I was doing my master's degree, and I'd gone to Australia to do some training with the heart research, the Australian Heart Research Council and secondary prevention. And the diabetes nurse talked to the students about insulin. And I'm like, I'm just doing advanced nutrition at Otago University, and why have I never heard of insulin before? But you know, my point is that people like me are not going to change the doctors' minds. It's going to be people like you. So I'm forever grateful that, you know, COVID's brought one great thing, which is this big, wider world community. And I can get to share you with people.
Right. And here's the other thing. The other reason why these doctors were interested is because they saw, I mean, you know, first of all, they saw how we looked. But not only that, when I started going through, you know, what you can see, but you can't even see the most important things. And I told them about the arthritis I had. And the interesting thing is I see them nodding because I know they're having all these same things too. Yeah. You know, the colds, the flu, just feeling like you're broken down and old, and the reflux. I mean, all these things. And I know that the doctors are having this stuff themselves. And when I tell them that, we made these changes and now just gone. I told them this, that I used, my knees were so bad. I used to have to take 800 milligrams of ibuprofen, to get out of bed sometimes. And I said, I haven't taken a single one in 3 years. And that's with me playing tennis every day and lifting weight and I never get injured. And I tell them, I said, this isn't because I work out. I said, this is 100% because of what I eat, what I don't eat, and how often I eat. Yeah. It's 100%. I used to say 90% because I do work, but I said no, because I was always working out. And even when I was feeling crappy and my knees were, I was running and doing everything then. It's 100% what I'm putting in my body. And so when they see us and then when they talk to us, of course they're interested, because, I was talking to one of our classmates from 30 years ago, and she was saying, yeah, I've had these bad knee pains, and I was like, yeah, I used to, and I don't, so yeah, I think results matter. I see a lot of doctors who are pushing the party line are very unhealthy themselves. We were very unhealthy ourselves, so I'm not saying that to be judgmental or anything. I mean, we were unhealthy, but when we made these changes, then we got super healthy and we feel great, and everyone wants to feel better and not have to take a whole bunch of medications. So, yep.
Right, I've got another interesting question here. Okay, so I'm a type 2 diabetic, and I have lost 15 kgs, but my problem is that my blood sugars are still very high, and my triglycerides are very high, and I've had pancreatitis. So could the high fat, low carb diet be aggravating this, and why?
Yeah, I'm not an expert on this question, so this is probably going beyond my scope. I have heard that some people can't tolerate a high fat diet. So yeah, I'm going to have to pass on this one, because this is just not my area of expertise. And not only, it's not something of my experience. I just, both of us.
I wonder whether, I don't know what your experience is with LADA, late onset, sort of type, I think they call it type 1.5 diabetes, and whether rather than being a type 2 diabetic, perhaps they're on their way to being a type 1.5, which might mean they don't have enough insulin available, or they may be getting to that point. Yeah.
I guess one thing, there's Richard Bernstein.
Yes. Yeah.
Oh, yes. Yeah.
He is someone he's a type 1 diabetic. He is in his, I think, early to mid 80s. He is thriving. Yeah. His hemoglobin A1C is in the high 4s. And if that's indeed the case, because that's something that the patient may want to research, or he has books out that you might want to look into. But there are some people who approach keto in not just high fat, maybe it can be low carb, low fat, high protein.
Yeah.
So if that's an issue with, fat that you're concerned about because of the pancreatitis, then maybe they can reduce the fat, but increase their protein.
Sounds quite a sensible, logical way to go.
Yeah.
I've got another question here. So you were talking about the evolutionary context of LDL. So can you talk a little bit more about that, and whether LDL was an issue evolutionary from that context? And I'm just going to mention here that, I've got the ApoE44 gene, which is one of the oldest genes that we have, and is probably related to my very, very high LDL as well. So yeah, I'll just throw that in there as well.
So,
Leon, I've given you screen sharing ability.
Okay.
As well,
well, I mean, I wasn't going to talk specifically about evolution of LDL, but I wanted to see if I can open this. Hold on a sec. Let me see if I can get this file, because I had it on the other computer, but we couldn't hear us.
Of course, yeah.
So let me just go to.
Because I know you had something you wanted to share.
Yes, I did. Let me just see if I can open this one. And let's see. Okay, yeah, I guess I'll use this. Okay.
Make sure you can.
No. All right, I'm just trying to see if I can.
Well, I'm pretty sure I've given you sharing options.
Let's see. Yeah, I'm gonna do it. I just want to see if I can open this file on this computer. I might have to download Reader. Yeah, just give me a second.
Just have a look and see if there's any other questions coming.
Yeah, we do. Yeah, just so I'll move on to them. But once I download the Reader, I'll show you what I wanted. Yeah. Okay. So let's.
How often should cholesterol be checked? Is that something that you think should be checked regularly, or?
Well, I can tell you for myself, again, it's in the context of being otherwise metabolically fit. I check my cholesterol, but I'm more interested in my triglycerides and HDL than I am in my LDL and my total cholesterol. And I guess I check maybe once a year. Some people check. I mean, how often do you check your?
Yeah. I mean, at first, when I was new to lean mass hyperspon, I was probably checking it every few months. Now I only check it once a year. But again, I think the important numbers are the triglycerides and the HDL is what I think are the important. And more important than that is, I think, the markers of metabolic fitness. So, I think if you could check your insulin, your blood sugar, of course, your blood pressure. I mean, I think all of those things, the numbers say that those are the more important factors anyway. So, but I'd probably check it once a year at this point. Now, again, this is because we're metabolically fit. If you do have metabolic dysfunction, then that might change. It might be something you want to check more often.
But basically, you're checking it for the triglycerides and the HDL number.
Exactly.
Right, yes. At this point, I'm not concerned about my high LDL and high cholesterol. I'm more concerned about the other markers that are more important, which I believe are more important.
And those ratios as well.
Right. Yeah. Exactly. The ratio, triglycerides to HDL ratio.
All right. How's that going there?
Okay, it's almost installed. Yeah, what happened was, I had a PDF file. It was on the other computer, and I just needed to download the Reader to put it on this computer because we had to switch to this one. So yeah, it's just kind of slow, but it's.
Would in the meantime, while it's downloading, I presume that maybe the slide was going to match talking about that evolutionary context, though. Humans have been evolving for a couple of million years, and how many different generations of us there have been, and then we're going agriculture in that short space of time, relatively.
Yeah. Okay. Oh, it's 6. Basically, all right. Well, I'll start talking about it, but I really do want to show the pictures because it really will make it very clear to people. Yeah. I mean, this is actually the stuff I show my patients as well. But I actually might be able to. Let's see. Downloads. I mean, I guess I could use this. I just, oh wait, oh no, maybe I can do, okay, let's see. Okay, it looks like it's, yeah. Okay, great, we're in business. Okay, so now let me go to share screen. Let me go to the page I want. Yes. Okay, whatever, jeez. Now it's making me do a whole bunch of other stuff too, because it just installed. Okay. All right, great. It's just,
Technology for you. It's wonderful when it works.
I mean, yeah, it's working. It's just sooner. Okay, great. Finally. Let me go to. Okay, so now I'm going to share my screen. All right, let me go back to Zoom. Okay, now where do I do that? Share screen, yes. Oh, it says host disabled participant screen sharing?
Yeah, I have enabled it. So who can share? We'll try again.
Okay.
Just try that and see if.
Try it now?
Yeah, try that now.
Okay, share.
Is that working?
Yeah. Hooray! Okay. So, all right, finally. Okay, so what you're looking at here is the insulin response curve of when you eat carbohydrates versus when you eat fat. And you'll notice that this is from, I think, from Paul Mason's lecture, one of his lectures. And you can see that you make a lot more insulin after you eat carbohydrates than when you eat fat. I mean, fat is only like 40, it's like more than double. But here's the thing. For most of human history, the carbohydrates that would make you make this much insulin probably didn't even exist. And I'll show you why. Okay. So what we're looking at here, you see this little like straw looking thing here? Okay, so this is corn, the way it appears in nature. Okay. But now you probably never see this at your supermarket. You see what's on the right here as corn. All right. So what's the difference here? Well, this corn that's on the left, this is called Teosinte. And for the 2 million years that humans existed on this planet, prior to our invention of agriculture, which was only 12,000 years ago, any corn that you would eat, this was the corn you were eating, Teosinte, because this is wild corn. All right. So how did we get this stuff on the right? Well, humans are clever and we like stuff that tastes good and starchy and sweet. And so after they invented agriculture, they figured out that if they found a piece of this Teosinte that was a little starchier, a little sweeter than the other, if they just kept selectively breeding it together over and over again, that's how we turned Teosinte into modern corn. Okay. But understand that this Teosinte has 1/3 of the carbohydrate content per gram as this corn that you buy in your supermarket. So for 2 million years, you were eating a very low carb version of corn if you ate corn at all. All right. So Teosinte would probably make your insulin, it wouldn't be anything like over 100 like it is here. It might be, again, it only has 1/3 of the carbohydrate content. So it would be much lower. And this is the case for every single food, plant-based food that we have. The wild form, and you can look this up, just look up wild form of pineapple or wild form of, and then you look at the pictures of what it looks like when it grows in the wild and what it looks like when you go get it at Whole Foods or your produce section of the supermarket. And always, it's much less starchy, it's much less sugar content because humans like stuff that's sweet and starchy. But the problem is we didn't evolve eating stuff that's sweet and starchy. We did not evolve eating what we get in the supermarket now. And we did not evolve eating foods that make your insulin do this, go over 100 international units per ml, okay? So that means for 2 million years, this was how our physiology was evolving. And 2 million years, that's like 100,000 generations of humanity. And evolution is very slow. But all the evolving that our physiology was doing, it was doing with this kind of food. But now in our modern world, all the fruit you get, all the corn you get, all the fruit, all the pineapple, mango, all that stuff that is natural is also much more carbohydrate laden, and it's going to make you make a lot more insulin. So now I'm going to show you this. Now, this is another one from his lecture showing where protein fits in. And you can see protein is sort of in between. This lower graph here is fat. And then this middle one here is protein and then carbohydrates. But you see carbohydrate is by far the highest, by far. Okay. So anyway, so the point I'm making is that we for 2 million years, we were not making a lot of insulin. Why? Because the foods that could make you do it didn't exist. I mean, the only thing that might be able to do it back in the first 2 million years, maybe honey, but no one was eating only honey. Okay. So basically,
you got honey, you got
it was
Exactly.
seasonal and
or you got honey when you,
depended on
yeah.
and regional as well. So
right. So basically, I tell people that humanity evolved as obligate intermittent fasters on a low carb, high fat diet. And now this McAfee thing's just popping up. I'm not gonna, how do I skip? Sorry.
that's so good.
Okay, because I just downloaded this, so of course you get all these other things.
Yeah.
Okay, skip.
Spend your money with me.
I'm sorry.
That's
Okay,
it.
let me just X that out. Okay, so so yeah, so basically I said that we evolved as obligate intermittent fasters on a low carb, high fat diet. And then when you think about it that way, then you start to think, well, why do we make insulin in the first place? What is the purpose of insulin? Well, it's basically the way we survived those first 2 million years before we had modern agriculture, and certainly before we had things like DoorDash and Grubhub and supermarkets. Food was very hard to come by. We were hunter-gatherers, and so basically all you ate was whatever you could hunt, gather, and or kill and catch. And those foods that you got were not going to make you make a lot of insulin. But the insulin that you made was then directed your body to store fat until that next meal. And that next meal was not going to be lunchtime 3 hours later or dinner. It wasn't 3 meals a day with snacks in between. That next meal might not be for days. Okay. Because again, no one's that good a hunter that they could hunt enough to have 3 meals a day with snacks in between. That was just impossible. So that was the whole purpose of, that's to me is the evolutionary purpose of insulin. It's a survival hormone. It allowed us to survive those 2 million years of food being precarious. Okay. So you'd make a small amount, you'd store fat, you'd live off that fat until your next meal. Now, look what it's become now. Now you're making way more insulin than was ever humanly possible because we now have the foods that can make you make this much insulin. So now you're making over 100 international units per ml. And then 3 hours later, you're eating lunch and doing it again. Okay, and then after that, you're doing it again for dinner. And that is just not how first of all, that's not what insulin was for. You're not surviving if you're spiking it every 3 to 4 hours. And there are harmful effects I think, of this chronic hyperinsulinemia. I mean, when you're chronically hyperinsulinemic, your blood pressure goes up. Eventually, you're going to become insulin resistant. Your blood sugar will go up. You are in a higher state of inflammation. All of these things from making too much insulin and making it too often. So, the hypothesis for me is that what we're doing in the low carb, high fat, time restricted feeding space is that we're trying to do what's evolutionarily appropriate for humans. Okay, we're making less insulin because for the first 2 million years, we were making less insulin because modern corn and modern fruit and, with all their high sugar content, they didn't exist. They couldn't make you make this much insulin. So we're making less insulin. We're making it less often. Like I said, hunter-gatherers were not eating 3 meals a day with snacks in between. It was impossible. So that's why we're eating, time restricted feeding or intermittent fasting, where you eat between a small window and then you don't eat after anymore. So that's what we're doing with that. And so by doing that, that's how we've made ourselves healthy, which then informs me that the reason we had all those problems in the first place is because what we were doing in our modern lifestyles, and this would be included if you followed the dietary guidelines to the letter, which I did, by the way. If you do exactly what they tell you to do, plant-based diet, lots of small, meals dominated by carbohydrates, if you do exactly what doctors tell you to do, you are going to be chronically hyperinsulinemic compared to how we were the first 2 million years. And understand that agriculture, 12,000 years, that's only 600 generations. And even even in that time, I mean, most people were still not eating like we're eating in the last 200 years, the way we're doing since the industrial era. And that's only 10 generations. So we're making enormous amounts of insulin. We're making it way too often. And then we're doing one other thing, which was impossible to do before 1866. We're consuming these vegetable seed oils. Now, how can I say with confidence that we were not doing this before 1866? Because they literally did not exist before then, okay? There was no food on this planet that had the concentration of polyunsaturated fatty acids that you get in these seed oils. And the first one was invented in 1866. That was cottonseed oil. And it was originally used to lubricate machine parts. Should have stayed that way, but then they started slipping it into our diet. And then based on absolutely zero evidence, they turned around and said that this was good for you, and the fat from animals and, you know, particularly like lard and beef tallow, stuff we'd eaten for 2 million years, that was causing you, you know, heart attacks and all this stuff based on zero evidence. But it doesn't make any sense, right? So, but this is the other thing that we're doing to our bodies that literally our evolution did not prepare us for, okay? This, I think, is from Chris Kanabe's lecture.
Yeah.
And I know this is from his lecture. I just think this is funny because he says you must eat more healthy polyunsaturated fat like Americans. And then he shows, you know,
Oh, and this is exactly what our dietary guidelines tell us to do. It's
exactly.
It's what the Heart Foundation guidelines tell us to do. Replace that saturated fat with these.
And here's the thing.
It makes your cholesterol look like it goes down.
Right. Yeah. But here's the thing. Our food consumption data proves that we actually followed those guidelines. Right now, the most prominent fat in our diet are these polyunsaturated fatty acids. Food consumption and production data proves it. We're eating a lot less saturated fat, and this has become the dominant fat. And this, unfortunately, is becoming the dominant body type of the Western world. Now, here's also from Dr. Kanabe's video. Here's a population that has no polyunsaturated fatty acid seed oils. And, you know, they don't get any heart disease. They don't get any colon cancer. Oh, wait, that's me. Oh, that was me before. So basically, when I talk about evolutionary appropriateness, I'm talking about not so much trying to say that everything in the past was better for us, but just that we evolved doing certain things and we were formed by our environment. And our environment was a low carb, high fat, low insulin secretion, infrequent insulin secretion environment. That is what forged our physiology. That is the reason we make insulin. We were never supposed to be pouring it out 3 to 6 times a day, every day of our lives. And the natural outcome of doing that, and also we were never supposed to be eating the seed oils, okay? And what has happened is, you know, you can look around you. Everyone by the time they're 30, they're starting to get a belly. Certainly by the time they're 40, their blood pressure's going up, their blood sugar's going up. Whereas in these populations that don't have any seed oils and they don't have our processed carbs, people our age, you know, look like this, you know? So yes, so this is what I meant. This is what I mean by try and think of things in an evolutionary context. Now, as far as where does LDL fit in that? Well, I honestly don't know because, I mean, who knows what people's LDL were during the first 2 million years? I don't know what it was. But what I do know is that, at least in modern times, there's so much data of people with high LDL being very healthy. Matter of, as I said, decreased mortality after 60. Another study, I think Paul Mason talked about, where they showed that higher mortality is associated with decreasing LDL in the elderly. You know, so there's just so much data to say that they're barking up the wrong tree.
I saw that way back in the 1990s when I was doing my when I was studying at Otago, and I distinctly remember sitting there with a paper that showed that at over 65, the higher your LDL was, the better your longevity, you know. And I remember laughing and saying in class, oh, so when you're 64 you're going to die, and when you're 65 you're not. And everyone's like, shut up, slow, you know, it's 5 o'clock on a Friday, we want to go home.
Right.
I've got another really good question actually, which I think would be great, and it'll be a great question to kind of start wrapping things up with. So says, thanks so much. It's been really interesting. My husband is 65 and has been on low carb and intermittent fasting for the past 5 years. All his markers have improved, but his blood pressure is still high. He's on blood pressure medication and statins. When he went off statins for 3 months, his cholesterol went up markedly. Needless to say, the doctors said he needs to go back on them. His calcium score is 205. So is that a factor in his high blood pressure?
Yeah, see, now this is where I
would you be able to maybe stop the screen share, and then we'll be able to see?
Oh yeah, sure.
Yeah,
Let
and
me,
then we can
go back.
Then we can see you properly.
Right. Let me, how do you make this bigger again? Okay.
You should just, I might be able to stop.
I'm trying to figure out that. Okay, here we go. Share.
No, I think I managed to do it from my.
You disabled it. Okay, good. Because I was going to be here all night. Okay. Yeah. So as I said, I mean, I feel very confident saying that if you're with metabolic fitness should be the goal. Now, if you're not metabolically fit, and if the blood pressure is high, and you have the coronary calcium score, I mean, that's significant. See, that might be an area where, I mean, I still think you try to do everything you can to be metabolically fit. But if you're doing that and your blood pressure is still high, yeah, there probably is a role, I would say, for the antihypertensive. And, and I think as far as the statin, it's one of those things where I might lean towards it in that situation if there's already evidence of atherosclerosis. Because as I said, even the people with familial hypercholesterolemia, some of them, did get heart disease early, and they were people who had metabolic dysfunction. And so if and she's already said the coronary artery calcium score and his hypertension, that might make me lean more towards treatment. Okay. But if you found a way to get that blood pressure, perfectly normal and all his other metabolic syndrome markers perfect, my personal opinion, if it were me, I probably, just from what I know about LDL and all the data, I probably would not be on statin. But if I was hypertensive and with that risk factor, yeah, I mean, I definitely couldn't argue with the doctor about taking that step in that measure. But for a perfectly metabolically fit person, no, I wouldn't. So
I think in this case too, there could be some value in looking at things like your ferritin, and whether if your ferritin is very high, and often in men, ferritin and iron will be quite high, and so doing some blood donations can sometimes help with that blood pressure. And then some other factors sometimes in high blood pressure are things like copper and zinc and iron, and those relationships as well. So that can be there can be some opportunities to go and have a look at some other nutrient markers and see what their involvement is in that elevated blood pressure, and maybe work with some of those a little bit just to see if that will help bring it down. With a CAC score of 205, what are your thoughts about that? I mean, what do we know about that? Is that from previous lifestyle? Do we know whether that's stable? Would you recommend having that tested every year? How would you manage that?
On that one.
Well, I mean, the CAC score is a measure of the load of calcium seen in the coronary arteries, and it's in a special CT scan. And, the ideal, what everybody wants, is a calcium score of 0, because that means there's no evidence of calcification in the coronary arteries. And so but if you had a calcium score of 0, then, you know, this question would be so much easier. But this person has evidence of coronary artery disease. And again, an isolated one tells you, you know, shows you have coronary disease, but it can't tell you what was it, you know, 2 years ago, what will it be, you know, 5 years from now. So a lot of times you see having another one can give you more information. The goal is if you have a coronary, you know, high coronary artery calcium score, and you implement changes in your lifestyle to hopefully reduce your risk of coronary disease, you want to make sure there's no progression. Because I think I'm trying to remember what the percentage of, if you see, I think it's within, is it 10%? If you see within only a 10% worsening, then that's better than if you see something more than that. And that sort of, that gives you a sort of an idea as if you're sort of getting into a more healthy existence.
So maybe,
yeah,
how frequently do you think it should be checked, Tamora? Do you think, yeah, hard to know.
Yeah, I think, yeah, I'm not a cardiologist, so I can't give you specifics, but I mean, and you have to be concerned about having just radiation exposure. So it's not something you want to do like
all the time,
every year. Yes, all the time. But I know some people maybe wait every couple of years, every 3 years to have a repeat scan to see what the change is.
Here's a point I want to make about you know, low carb, high fat, intermittent fasting, all of these things, is that a lot of times the human body can be very forgiving. It was certainly for myself and for Tamora. But remember what I said, the corollary to these measures being anti-aging is that the lifestyle that you change from was pro-aging and was doing things for decades. And the reality is that, you know, sometimes, you know, even if you're doing everything that you can, it might not make things go all the way back to where you want them. Like, for example, I am of the mind that cancers, or the majority of them, I'm convinced it's a metabolic disease, and I'm not the only one who thinks that it's a metabolic disease. And I think it's largely caused by our environment. And I think that a big contributor to getting cancer is deficient immune surveillance. You know, the decreased immune, because I think that, you know, we would get cancers, but if your immune system tracks it down before it becomes a big problem, and that's a process that might be happening more frequent than we may imagine. But it can get to a point though where it might be too late, or the damage might already be done. So, I mean, like an example was my brother, who passed away from colon cancer a couple of years ago. And he, you know, we had talked about these things, and, you know, like how there are places where basically no one gets colon cancer. I mean, like the rate is 0, like the Maasai tribe in Africa. And it said to me that, you know, one of the things that I felt, and I don't know whether this is true, but I kind of believe it, that had he grown up with the Maasai tribe, he never gets colon cancer. Because, yeah, maybe he had some genetic predisposition, and, you know, we all have genetic tendencies for things to happen. But I'm also convinced that, you know, the saying of that genetics loads the gun, but environment pulls the trigger. And so in my case, the loaded gun was hypertension and obesity and a pulmonary embolus. In Tamora's case, it was diabetes and reflux and things like that. But then when we stopped the environment, when we stopped pulling the trigger, right, everything went away. However, things can get to a point where even if you then, you know, stop pulling the trigger, it can be too late. And that's unfortunately what I think, you know, certainly with cancers, and it might also be the case if you get far enough along with metabolic dysfunction that you have coronary artery disease, you know, or cardiovascular disease. I mean, it's possible that these things, you know, that we say that work really well, but it may have its limits too. You know, if it may have been something that, if it had been 10 years earlier before you were at a certain point, yeah, now like myself, I mean, as I said, all these things I had are just gone now. But what if I had started this with 10 more years of me doing, you know, the dietary guidelines and consuming the seed oils and and being chronically hyperinsulinemic, would it have been as successful? So that's the one thing I want people to keep in mind is that I mean, I think the ideal thing would be for all of us to treat our bodies to what evolution forged it to handle from childhood. And we have our children doing this, I mean, they're young adults now, but I'm like, I tell them, I mean, they saw what we've done and they do what we do. I mean, not exactly, but very, very, pretty much like what we do. Because I told them, I said, I don't want you getting a pulmonary embolus when you're 52. If you can avoid that, and avoid having terrible knee arthritis and all this stuff. And, just you start now, and that would be the ideal thing. And I certainly think it's always better to start than to never start. It's always better to do things that would make you metabolically fit, but just understand that it's possible that even with you doing all these things, maybe the blood pressure doesn't come down. Maybe, I mean, you still try your best, but that's why I'm saying there might be a role for, if you've done everything you can with diet and your blood pressure's still high or your LDL, and then in that case, your LDL is high as well. Yeah, that might be a case where you probably may need some help with some medicines. But if you're metabolically fit, no. And I say hard no on all medicines if you're metabolically fit. So I mean, that should always be your goal.
And I think this is a great opportunity to start wrapping up. Thank you so much, both of you. But I hope people will share this and the other interviews I've done with you. And, there's a lot of people out there sharing this information. I hope they will share this with younger people, because the more we get this message out in New Zealand, but not only in New Zealand, worldwide, this is a massive problem. So
yes.
I really,
but it can have happy endings.
It can have absolutely happy endings.
It can have happy endings. Because I'll tell you, I just have to say, I mean, when I was 52, I remember this. If you would ask me how I was feeling, I would have said, I'm feeling okay. But then when I really look back, when it was like, I was feeling old and tired and achy. And again, I just thought, 52. And the thing is that now 5 years later, and I'm like this, and it's like, I mean, I can't believe that I thought that was normal. And so what I want is for people to not have to get to the point where I was at 52, but just to jump straight to where I am now and start that when they're in their 20s or they're in their 30s. Don't abuse your body for decades and then try to undo it with medications or then start treating your body like evolution intended. So yeah, I mean, it can have a happy ending, I think. Thankfully, the body can be very resilient. But I just think we have to treat it to what evolution said is how it's supposed to work. Okay, so yeah.
Well, I am so grateful to have both of you in this space, and I love your passion and how much you share, and that you just give up so much time, like helping me with this as well. So I'm really, really appreciate it. Thank you very much.
Oh, certainly, it's our pleasure. Our pleasure.
All right, well, I better let everybody head off and do their things. And yeah, it's been such a pleasure again. Thank you so much.
Okay, thanks, Sue.
You're welcome.
Okay.